Hello, I'm Norman Swan. Welcome to this special Rural Health Education Foundation programme, which is on the Doctor of the Future. And someone who's given that a lot of thought is Professor Des Gorman, who's Dean of Medicine at the University of Auckland. Welcome, Des.
Thank you, Norman.
Now, look, when I was in medical school, we were talking about the Doctor of the Future. Nothing much seems to have changed. Why are we talking about it now?
I think we've got to a point of health workforce crisis, Norman, where more of the same is simply unacceptable. One of my favourite philosophers is Jean-Paul Sartre, and his concept was that to do nothing actually is to choose the status quo. And if we look at the status quo and say, do we have equity and quality in our health systems, the answer is quality is variable and equity is often poor. So you'd have to say today there are real issues around the adequacy of health services. If we then look at how Australia and New Zealand is going to age over the next 20 years, and Australia will age proportionally more extensively than New Zealand will, and say, well, what are the implications of that to health services? For the New Zealand perspective, we need, best case scenario, if everything goes swimmingly well, 40% more health providers. More likely, somewhere between 70 and 100% more health providers. If you take Australia, which will age even more so than New Zealand, you're probably looking at a doubling of the health workforce at a time there'll be fewer taxpayers. So the New Zealand perspective is our health budget will double if we continue on the way we are, with fewer taxpayers. So,
but just before we go on, just to question that, I mean,
yes,
these doomsayer things, we were told the obesity epidemic is going to lead to demographic collapse. It hasn't yet. The likelihood is that the same causes of extended years are also the same causes of extended years of disability-free life expectancy. Older people seem to be underutilising health services relative to their age. I mean, are we really looking at this disaster
yes,
scenario?
we are. The factors that I figured in there assume that you'll be able to compress morbidity as much as you can at the end of life.
So
that's
we'll
an
live
assumption.
longer, healthier.
Yeah, that's right. That's an assumption. What mitigates against that? There is an epidemic of diabetes in place. Amongst Maori New Zealanders, for example, it's 1 in 4. And that unfortunately carries with it both a social and a medical and a personal cost, which is huge. The other thing, Norman, is that even if, let's say, we do twice as well as we think we're going to in terms of compressing morbidity, I don't think we will. And the reason for that is that the preventive medicine agenda is run by white, middle-class people with certain health perceptions. And there's a incredible fallacy in place that investment in preventive care enables a disinvestment in clinical services. Investment in preventive care generates a healthier, more productive community.
But the health dollars will still be spent at some point in the future.
You're going to die. You're going to get sick. The thing that will mitigate against any compression of morbidity is the medicalisation of society.
What do you mean?
We now interpret our lives in medical terms. People, the things that our grandparents assumed were normal life experiences, people now want medical explanations for and a magic bullet. The best way to describe this is the affluent, well, worried, sick. The people who consume more and more health resource. The investment in the health disease industry and the pharmaceuticals in maintaining that anxiety is extraordinary. And I would see, when I do a clinic, I would see only 2/3, maybe 3/4 of patients I used to, because I spend the first part of each session often wandering through the 3-inch print of internet material and dealing with the preconceived health anxieties. You would need to see a dramatic shift, not only in morbidity, but also an equally, or perhaps even greater, more dramatic shift in people's perspective of their lives and this demedicalising of society. And in fact, the economic drivers at the moment are the dead opposite. So,
but again, just to challenge you before we get on to what your concept is, so just on these premises.
Yes.
I don't know about New Zealand, but you know, almost every little place in Australia, I'm exaggerating of course, seems to be setting up another 2-bit medical school. We're producing medical students all over the place. Goodness knows how they're getting taught. We've got this, and if you talk to medical students now, they know a tsunami is behind them. They want to get into training as quickly as possible because they know there aren't places for those medical students coming out to be trained in this so-called shortage. In other words, they know there's a glut coming.
Yeah, I don't think that's right. The tsunami is certainly talked about, but I'm not sure that's right. Australia is a very major importer of doctors, but a very low exporter. New Zealand, tragically, is a heavy exporter and importer. If you look at the OECD data, the Australian health system imports a lot, exports little. What will happen is that Australia will remain very reliant on imports for the next 20 years. And in 20 years' time, when steady state arrives from the new medical school classes now, you would still probably see at least 1/4 of the current level of imports being required for steady state numbers. That's assuming doctors are doing in 2020 what they're doing in 2008. The problem with the tsunami is that the Australian health workforce training process reacted far too late and didn't have time to build up the capacity in the training programs. What you described to me is not that the numbers are wrong, but the capacity of education didn't exist. What you're describing there is not a problem in the health workforce planning, although it's probably wrong, because all health workforce planning is wrong, because it's always a wild guess. You imagine when you and I are students trying to forward think in any shape or form about the technology and the situation of today, we would have got it. Anyway, come back to the point. The problem with the 3,500 medical students per annum in Australia has been the rate of implementation of the numbers and a speed which didn't allow capacity building. You don't just wave your magic wand and create academic institutions with learning capacity. So that's a capacity issue. It's not that the numbers are wrong.
So let's then move. So let's assume for a moment there is an argument for a change and a changed environment with an older community carrying more disabilities at a later age, and perhaps in a system that's less capable of affording the sort of healthcare we've got now, perhaps. So what's the story? What's your vision?
I think, Norman, we're at a point in time where it's appropriate for us to revisit the very basis of what we think doctors are and what we think doctors do. My view, you asked me before, at the beginning, you made the point that we've been talking about these sorts of things, the doctor of the future, and you and I are medical students. The difference was there that we said, here is a paradigm of health delivery, doctors and nurses, and what we're going to do is we're going to determinedly fit the community needs into this paradigm, and basically we'll flex this like this, but what we won't do is address whether this paradigm's right. And I think for a long time, probably the last 200 or 300 years, that's exactly what we've done. We've said, this is the model of healthcare. We need to redress and redefine community health needs until this model of healthcare meets it and satisfies it. The point I would be putting is that, well, that's not right. What we need to do is actually define those health needs first and then look at a health service which takes into account the realities of our last 200 or 300 years of experience, which is that we don't predict health needs in the future very well. Health needs change almost if someone discovers that peptic ulcers are caused by a bug, we wipe out all the gastric surgeons are wiped out overnight.
So what you're describing here, as complexity theory talks about this, is if you've got a changing complex situation, you need a core set of principles or attributes which allow you to then presumably be flexible.
Precisely right. And yet if you look at the way in which our profession's configured, it is silo-like, it is inflexible, and of course that lends it to a
And the set of attributes is 3 volumes thick.
Oh, absolutely right. And also we've been obsessed with the facts of medicine, whereas in fact we have trained doctors out of any form of intelligence by inculcating them with a set of facts which you and I both know to be heavily flawed. The other issue that while we're talking about this inflexibility is the reality of 2008 is that 55% of our graduates are women. Now those women are going to drive some changes into medicine, whether we like it or not. The white male dominance of the colleges, which prevents any form of flexibility, interrupted training, disconjugate training, cross credits, will not be acceptable to a female-dominated profession. And one of the issues that I'm trying to get my head around is, what will success look like in 2020 or 2030? When most doctors are women, what will success look like? Will it look like success today? I don't think so.
So what will success look like?
I don't know. But
what do these attributes look like? What are the core things, the absolutely irreducible things that doctors got to have?
That's a different issue, isn't it? And I think the idea of what success is will sort itself out in time. But at the moment, the success is someone who trains in a mainstream discipline, and of course we still use the word specialist, which actually is very pejorative to our general practice colleagues. We use the word specialist, and the successful doctor is someone who gets into a highly valued speciality, which is very well paid, works his way through that speciality, ends up becoming a professor somewhere and esteemed in the community, and that's success. In reality, success may be in 2020 the female graduate who's gone into general practice and then gone and done something else, who's had a successful family and who's done bits and pieces, then realises the need in obstetric services and retrains in obstetrics. That's a very, very different concept of success than the, if you like, mono-career individuals.
So the doctor of 2020 is much more redeployable.
Absolutely. Anyone who looks at the experience of the last 20 years and says that the silo system's appropriate, or that an inflexible system, the training is appropriate, it is gobsmacking, isn't it, that we still have college training schemes. Well, I'm guessing 75–80% of the teaching is common, but where they're siloed, where there's no cross credits, where you can't retrain, cross-train, redeploy. It is unacceptable in any system which takes as its starting point, we are guessing about the future needs and we're going to get this wrong.
But how do you, particularly when you've got fees for doing this, either full fees which are going to disappear in Australia, but at least you come out with a debt, and you've got this enormous sucking vacuum of the many $100,000 salaries of procedural specialists versus what you're going to earn as a generalist.
It's very true. Australia's had 2 cracks at a relative value study, and on both occasions the politicians have backed down on the basis that I suspect the worst thing a politician can imagine is a headline in the paper saying hospital waiting lists blow out.
Or orthopaedic surgeons resign.
Exactly. And they haven't had the courage to follow the relative value studies through. 2020, 2030, I can see the orthopaedic physician and the bone setter. In other words, going back to a model of healthcare delivery which made sense when we didn't throw truckloads of money at health. The orthopaedic physician being the person who diagnoses orthopaedic related problems, may be involved in some difficult procedures where the procedure is actually problem solving and where there's an added value to it. But having aligned professionals who do the bone setting and so on, who are technically expert but don't require the scientific basis and the evidence predication which underpins the problem-solving role. Now what we need to do is actually make sure that the incentives, the alignment is that it's for the cognitive resource, not the banging the bone with the chisel. Now sooner or later, as these health budgets get unmanageable, sooner or later, there's going to be a need for a relative value study and for some political determination to see it through.
And just talking about this redeployability in the generalism, I think that there are very few general surgeons, general physicians being trained in Australia. And some cities like Sydney are particularly badly off. And the trainees of 2020 are already in medical school.
That's right.
Sorry, I mean saying the specialists of 2020
That's
are already in medical school.
That's right.
You haven't got much time.
No, in fact some people would say that we probably have already missed the bus for the 2020 problem. It's not too late to use some reasonably crude levers on career choice. And you mentioned indebtedness, for example. Indebtedness is a very obvious lever for career choice by way of debt forgiveness schemes, and that's one way of manipulating choice. The alternative to a relative value studies which re-incentivises generalism, Norman, in my opinion, is the sorts of dichotomy we see in North America today. 16% of GDP, 45-ish million Americans no access to health care. That's what happens when you allow non-aligned resources. It may even be that there's enough doctors in America today, but the malalignment is so severe as to create this sort of dichotomy. So the question Australians need to ask themselves, is that our future?
What about professionalism? We call ourselves a profession, but sometimes things like the problems, enormous problems we've had with safety and quality have been ascribed to the fact that we are a profession, self-regulated, and we don't actually behave like a profession very often.
That's true.
So is there any value in training a professional as such, or should we be trading more as a trade that's protocol driven?
Yeah, good question. Well, first of all, protocols, let's start with the end of your question. Protocols and guidelines only influence behaviour if it's Bayesian in nature. And most of the decision making, certainly in many areas of medicine, is not Bayesian at all. It's driven by social prejudice, bias, access to health care, avoiding complaint. And you can have 3 million protocols or guidelines, but if they don't address the things which influence clinical decision making, they're a waste of time. They are attractive to health ministries and health managers, but they don't have a lot of utility on the ground. So guidelines, first of all, only will be useful when practice is fundamentally Bayesian, and right now it isn't. In terms of the rest of your question, can you remind me?
Which is about profession,
yes,
being a profession.
Professionalism itself.
Because you talk about breaking the mould.
Yes, I am.
And yet you talk, when you're writing, about maintaining it as a profession.
Yes. There's a difference between the guild, which behaves like a guild, which is self-serving, self-maintaining and self-sustaining, which is what attracts appropriate criticism, and professionalism, which are around domains of communication, ethical behaviour and so on, which in fact is the fundament of what we do. The problem is that we've been trying to impose professionalism on our students by way of didactic teaching or small group, whatever, whereas professionalism, in my opinion, is learnt by role modelling. And what we're taking out of medical education is the opportunity to be an apprentice to a master and actually look at different models of professional behaviour. The ethics of being a doctor is an incredibly difficult subject. On the one hand, it is doing the right thing. On the other hand, it's challenging systems and people. That's dichotomous. So the very nature of ethical behaviour for a doctor is an internally conflicting concept. But I learnt it, you learnt it at the feet of people we watched and saw and said, I like the way you did that, I don't like the way you did that. And it was that modelling. And what we're seeing in modern medical education is a dismantling of the master apprenticeship system. So one of the things I'd answer to you is that we need to drive master apprenticeship systems back in, not as part of the guild, not as part of guild-like behaviour, but to provide models of effective professional behaviour.
Of course, that's been part of the problem, is that you've learnt at the feet of the masters, but the masters often say, well, I know best, and don't care what the evidence says, I believe that this works much better, and therefore the person who's learnt at the feet of the master starts behaving like that as well, not realising the master is in fact wrong.
I think that's true, but what we're trying to get students to do in 2008 is whenever they have encounters with masters is to reflect on what that encounter was and whether they liked or didn't like what they saw. The requirement for me running a medical program is to make sure that my students are exposed as much as possible to a broad range of behaviours, and so that through their process of reflection. See,
so you can talk back.
Absolutely. To me, my job is not to graduate people with a fixed set of moral values or principles. It's to graduate young doctors who have the ability to reflect and think and say, what was it about that I liked?
Now, you also talk about the doctor of the future being somebody who should recognise and be able to use innovative disruptions.
Yes, yes. Very Harvard-like, isn't it?
That's not the strike you're talking about.
No. Innovative disruptions is a concept out of the Harvard Business School, and basically it would be
the internet or
exactly,
something like
that's
that.
right. A personal computers disrupting mainframe computers. And
something we didn't predict that was going to come along that's changed our lives.
Precisely. And what normally happens, the established technologies or the owners of the established technologies see the new technology come along and fight it to death and say it won't work, it's no good, it won't solve all our problems. Instead of saying, how can I accommodate that disruptive technology? How can I accommodate
Can you teach
that perspective? Yes, you can. And particularly you can, again, by showing how those sorts of disruptive technologies can be employed and actually can be successful. Now, I know this is something...
Can you give me an example?
Yeah, well, I'll give an example of a failed case. The nurse practitioner was a disruptive technology in primary care, but in fact, the way it was presented to the general practice community was as a threat to their livelihood and to their status in primary care. So our general practice colleagues surrounded the wagons and decided to fight off the invaders. And the ambition there was to show that, in fact, the nurse practitioner was a crazy scheme. The nursing councils, thankfully for the GPs, joined in and made it so time punitive that very few nurse practitioners occurred. What we'd want our students to be able to recognise is that the nurse practitioner offers a type of practice style which enables the medical graduate to engage in those. Exactly right, and to do what we are spending so much money teaching them how to do, which is differentiation, problem solving, problem explanation, care, oversight. It makes no sense to me to have a receptionist or a nurse at the front desk differentiating for GPs running clinics, or like for a diabetes clinic or a sexual health clinic.
So you also say that another attribute is that you should be a physician scientist.
Yes.
Is that really, I mean, you think that everybody should be a researcher?
No, I don't. A scientist to me is someone who understands the importance of evidence and has a sceptical perspective. What we really want from our profession is skepticism.
That's another one of your attributes, is that the doctor of the future should be resilient and sceptical.
Absolutely, and that's going to require some training. There's some debate over the relative figures, but North American commentators argue that in North America there's as much money spent by the pharmaceutical industry, direct-to-doctor propaganda, as the budgets of all their medical schools and their training programs. And so, you know, I would cynically say that doctors are not accidentally stupid. The problem with direct-to-doctor propaganda is that it's dwarfed still by direct-to-patient propaganda. Our ability to see through that, propaganda, to see through those biasing phenomena requires us to be sceptical and resilient, and also to appreciate just how influential.
Well, tell me more about this resilience.
Resilience means that, resilience just means that you have the ability to remain fairly robust and rigorous in your approach, and that you understand that the propaganda you're exposed to is insidious, and that unless...
So do you think current doctors lack resilience?
I think they lack skepticism, and I think we were trained in a way which wasn't particularly sentient. For example, when you did your physician's exams and I did mine, I memorised Harrison's textbook of medicine. It was the most anti-intellectual thing I've ever done in my life, and I spent the rest of my life trying to forget it. Well, I was doing my PhD in Sydney many, many years ago, and I couldn't get an animal model to work, just would not work. And so for a year, I changed the anaesthetic, I changed everything I did, and it took me a year before I was prepared to say, what I'm seeing is what I'm seeing, what I know is wrong. Now, what worries me, Norman, is how many times in my life have I encountered things which are in conflict with what I know, and I've rejected them out of hand. I think we were trained in a very non-sentient way. I think we were coded with a head full of facts which we've carried forward for the rest of our lives. I don't believe that we were ever trained to understand the effects of modern marketing. I mean, we live in a society where people pay 3 times more for bottled water than they do for petrol, Norman. So what would make us think as a profession we're not profoundly vulnerable to marketing?
Now, you also say that another attribute, or I suppose competence, if you like, in terms of the doctor of the future is that you've got training in psychology, sociology, anthropology.
Yes.
But, you know, University of Auckland's been doing that for years. The medical school that I went to in Scotland, you know, we were the first university to teach medical sociology, and yet it doesn't seem to have made a difference.
Yes, it's a matter of how you teach it, the real worldness of that teaching it, and how you teach it in an applicable way. And I've just given you an example. Once you appreciate that you can get a community to sort of get rid of all the curves on their television sets and buy fat screen TVs or pay goodness knows what for bottled water, you begin to understand that there are some people who understand how to influence people's behaviour intimately. An example I often use is around health perceptions and the difference in health perceptions and understanding what, and we have a dreadful habit of assuming that our perspectives of health risks are our patients' or our community's perceptions of health risk. If we are to genuinely shift health at risk behaviours, we need to understand at a sociological level just what's underpinning them. What our students need to be armed with is role models and examples of effective medical sociology as compared. You and I saw it as something which was irritating and tacked on the side and distracted us from learning what we wanted to be learned. We wanted to learn how to treat patients. It's how you drive it into that process, so you need to understand.
So it's the context in which you learn it?
Precisely. I mean,
and presumably the pervasiveness, it's not just a course on a Tuesday morning in second year.
Precisely right. If you want to alienate or marginalise something, give it a special title, stick it 1 week in third year or fourth year, and the students understand exactly what that means. It means it's marginal, it's not central. And we have to bear in mind that these are young people wanting to be doctors, so you have to show them, I believe, why anthropological issues matter.
And finally, you say that the doctor of the future should have a cognitive and generalist focus.
Yep.
Is that just a bit too idealistic? I mean,
No.
when in the future, in 2020 or whenever it's going to be, and my knee collapses on me, I actually want somebody who's a really good knee doctor. I'm not sure I want a generalist.
I think you're right, but what you want is someone who's technically expert. Now, whether they understand the broad ramifications and depth of the nature of your disease, maybe that's a lesser evil, Norman, than them becoming technically expert. Fit for purpose, trained for purpose.
Touch my knee.
The trained for purpose technician is going to become increasingly common. But when we look at what doctors should be doing, and again, the best data come out of North America, the number of GPs that you have per capita is directly and positively related with quality and negatively related to cost. In other words, More GPs, up goes quality, down goes cost. Look at the specialist communities, the opposite's true. If more
But nobody's going into general practice in America.
Well, they are, but unfortunately they are recruiting our students. They still have the same number of general practice trainees, just in less than half of them are trained in North America. My great concern is the very people we need to keep most are the very people we're likely to lose. Because in fact, most people you can't train orthopaedic surgery in North America, but you can certainly get a general
But for you to get the doctor of the future, this cognitively based generalist, what happens in 5th or 6th year, or 4th year, depending whether it's a graduate course, and what you train them as an exit, could be cut asunder by the next 2, 3, 4, 5 years of what they experience outside.
That's true. The wasteland, actually, Norman, is probably the first 2 postgraduate years. The real wasteland is not the time at medical school or the college times, it's that transitional period. And getting some concept of the educational continuum becomes extremely important. It may be.
So medical school doesn't necessarily end when you've got your MBCHB or
quite the
MBBS.
opposite. And those junior doctors' years probably need to be under the aegis of an education authority rather than a service authority.
Well, isn't that the case? You've got postgraduate graduate medical councils.
No, but in fact they still have a significant service role. I mean, I'd actually challenge they do much service at all, which requires them to be trained as doctors. Our surveys in Auckland would suggest that our junior doctors
writing out path forms and discharge
Exactly.
summaries.
It's about 15% of their time is spent doing things which are required to be trained as a doctor. Now, the reason why it worked historically is that we weren't shift workers, we weren't unionised, and we were assigned to a team, and we were part of that team.
The old firm.
We were apprentices. So when you dismantle the apprenticeship system, the junior doctor training schemes, and replace it with nothing, you shouldn't be surprised that it becomes a bit of a wasteland. The answer about the generalism, by the way, is we have to be looking at providing role models for our students of highly attractive people doing general scopes of practice. Our students...
And interestingly, the rural procedural specialist, the rural general practitioner, is often that person.
Oh look, it amazes me that Australia had to advocate for rurality when in fact it's probably the most demanding, enjoyable concept of medicine possible. I mean, there is someone of high standing in the community who has a general scope of practice. And you and I both know that if we were sick this afternoon, we wouldn't go and see the person in the left anterior who's an expert in the left anterior descending coronary artery. We want to see a general physician because he or she is the most likely person to put our problem into perspective and get us to the right place.
And in some cities in Australia, you won't find one.
In many places of Australia, you won't find one. And you won't find any in training either.
So people watching us talk are people who are already in practice. And they'd say, well, you know, I'd quite like to be that now. How do I do it?
It's a good question. I actually think the reconstruction of the status of general practice and the reconstruction of the status of primary care is the great challenge we face in the next 10 years. And part of that will be diversifying practice. Part of that will be restoring into the primary care setting things that should never have been taken away. Part of that will be a economic realignment of need and supply. Part of that will also be the primary care community behaving professionally, stopping bagging themselves. When a lot of my students say to me, well, look, I don't want to do general practice, I say, why? And it's not what they saw, it's what the GP said to them. So GPs dress properly, dress smart, dress professionally, talk professionally, become advocates for your profession, and look not so much at what level of remuneration can I receive, but what sort of economics can I drive into my place by diversifying? What can I get? What are the returns on quality even? So I think reconstructing primary care over the next 10 years is one of the great challenges, because if we are to get our students to go there, debt forgiveness schemes will help, but what would really help is to have a professional group who our students really want to be like.
Des Gorman, thank you.
Thank you, Norman.